Hello and welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for October 15th, 2025. Thank you for joining us today, and thank you to the current Osteoarthritis Action Alliance sponsors who help support our work, which includes the monthly Lunch and Learn webinar series. Now it is my pleasure to introduce today's speaker, Theodore Pincus. Dr. Pincus is a professor of medicine at Rush University. His early laboratory research included a radioimmunoassay for DNA antibodies to recognize systemic lupus erythematosus and description of genetic control of experimental retrovirus infection. In 1982, he documented severe functional declines in premature death and rheumatoid arthritis, predicted by physical function scores on a patient questionnaire and by low socioeconomic status, far more significantly than by laboratory tests or imaging data. These unexpected observations led to asking all patients with all diagnoses to complete a multidimensional health assessment questionnaire, or MDHAQ, at all visits and a shift into clinical research. The MDHAQ is completed by most patients in 5 to 10 minutes and includes 4 indices. The Rapid 3, which is used to assess clinical status in patients with all rheumatic diseases, a fibromyalgia assessment screening tool, and depression and anxiety screening tools. The MDHAQ has been used to screen for early recognition of medication adverse events in non-rheumatology patients and has facilitated screening for anxiety, depression, and/or fibromyalgia, which have been recognized for decades in research studies and are seen in 35 to 45% of patients with osteoarthritis and other rheumatic diseases in routine care. Recent activities for Dr. Pincus include development of an electronic MDHAQ, now available in the EPIC electronic medical record, analyses of pain mechanisms in rheumatic diseases, and further studies of associations between low socioeconomic status and poor health. We are so pleased to have Dr. Pincus here today. The title of his presentation is Pain Scores in OA and RA Patients Unchanged Since 1979, Implications for Care and Research. Welcome, Dr. Pincus.
Well, thank you very much. I should add that the observations in 1982 were actually analyzed by Dr. Lee Callahan, the director of this whole program, whom I thank for inviting me to give this talk. And of course, thank you to the generous sponsors who support the infrastructure. You've already heard the title. I modified it just to point out that the data I'll be presenting are primarily in several settings, and I've tried to take the implications into 16 specific possible lessons for routine clinical care and clinical trials. I should disclose that I do receive royalties and license fees for copyright and trademark of MDHAQ Rapid 3. It was actually suggested by a pharmaceutical company about 15 years ago, and it's hard to say you won't take money for something you do for free. We don't have any license fees for clinicians who want to use it in care of their patients. If anybody's interested, I can send you copies, and I hope you can not make Xerox copies that come off the page, are for academic research. And actually, all the license fee funds are used to support further development of questionnaires for patients and physicians, which is in fact what you'll hear about in the next 25 minutes. The story begins about 10 years ago here when a registrar in Sydney, Australia at Liverpool Hospital named Carlos El Haddad pointed out to his mentor, Kathy Gibson, that the pain visual numeric scale in osteoarthritis, 0 to 10, was 7, and in rheumatoid arthritis, 4.3, and then looked at other features of the MDHAQ, which was being used in all patients at Liverpool Hospital, that the scores for physical function, patient global, and Rapid 3, which I'll show you in a second, were all significantly higher in OA than RA. Now, at that time, and to this day, I think many people regard osteoarthritis as the most common type of arthritis, with rheumatoid as the most crippling or disabling type of arthritis. And this is the MDHAQ. Briefly, it derives from the MDHAQ. The first 8 queries are verbatim from the HAQ. We added two about 30 years ago when the patients were doing better, walk 2 miles and participate in recreational activities. Three sort of psychosocial queries for sleep, anxiety, and depression. Two visual numeric scales for pain and uh, global status. You could recognize the three components are the three components of the rheumatoid arthritis core data set, and the RADI self-report painful joint count, which was originally developed for rheumatoid arthritis, but is then very useful in osteoarthritis and fibromyalgia. How do we do this? It's very simple. It's been going on for more than 40 years. The receptionist gives the patient a questionnaire. The patient completes it, and the MDHAQ takes 5 to 10 minutes for most people. And it's reviewed by the doctor. This is Dr. Bergman, in whose office these photos were made. I want to point out that 50% of approximately patients have told me doctors ask them to fill out questionnaires, which they never look at. That's a disservice to the patient, and frankly, I think reflects poorly on the doctor. This is a photo from 30 years ago I couldn't resist putting in with myself and a patient who had done very well pre-biologicals with 3 milligrams of prednisone a day and 20 milligrams of methotrexate a week for more than 20 years, and everything had been going pretty well. I will point out that this process may become obsolete in many settings by the availability of the MDHAQ now in the EPIC EMR. We still use the paper version, and everything I'm going to show you in the next 20 minutes comes from paper MDHAQs. Many people think this is important, and then they find some reason they can't make the point that if it's important, you'll find a way, and if not, you'll find an excuse. We then had the opportunity, the blue here is what I've been showing you, to look in 3 other settings: Rush, where I work, NYU with Yusuf Yazici, and Marty Bergman, who helped collaborate in the RAPID-3. And you can focus on the yellow on the right, which has the median of 4 sites, showing that pain score, function, and patient global were all about 1 unit higher, which is outside of the minimum difference that can be seen, indicating significant differences, and the same for RAPID-3. So it makes the second lesson, which is that there was poor status of OA versus RA patients at 4 sites in 2 continents. I'll again emphasize, we don't know this is true everywhere. If anyone has data, they should publish it, or if they're published data that I'm unaware of, I'd love to see it. I will note that this morning I listened to a podcast from ORSI, a live podcast called Real World Evidence in Osteoarthritis, getting more from observational data than correlations. This was mostly about registries. Our emphasis here, the third lesson, is that routine care of chronic and possibly all chronic diseases, not just rheumatic diseases, should include possibly quantitative assessment of physical function, pain, and patient global as vital signs, analogous to temperature, respirations, and heart rate in acute diseases. Although I will still say, including where I work, the acute care measures continue to be collected, while the chronic care measures, at least where I work, are also collected, but sometimes not at many sites. Then, as sometimes happens when you make an observation in an area you weren't really working in, you start to look at the literature after you publish your data. And we looked at this early paper by Huskisson, who had invented the visual analog pain scale, and Paul Dieppe, an authority in the 1970s on osteoarthritis. And actually, they had pointed out our thought to be original observation back in 1979, that pain scores in OA and RA were quite similar. It had face validity in that rheumatoid factor was much more common in RA, although it's noteworthy that 6% of the OA patients had rheumatoid factor. So lesson 4 is that OA was recognized to be as severe as RA from the patient's perspective, even back in 1979 and since then. Huskisson and colleagues said osteoarthritis was usually as polyarticular and symmetrical as rheumatoid. The knees and hands were most commonly involved sites. These findings do not support the concept of osteoarthritis as a mechanical, non-inflammatory wear and tear condition. The lesson from all of this is one should consult the old literature more carefully and regard it with relevance and some reverence some of the time. Again, this is a quote from a patient in a focus group published by Gillian Hawker and colleagues in 2006, almost 20 years ago, in which the patient said osteoarthritis is part of a normal aging process requiring acceptance, not treatment. What do you expect? You're just getting older. Obviously, hypertension and diabetes also occur with much more commonly with aging, but they're not inevitably part of the aging process, and it reflects misconceptions about osteoarthritis. Then we look back at our own data. This is Lee Callahan, not in 1989, who all you know organizes this program. And I'm showing you the new data here that way back in 1989, it had been observed that the pain score in OA was 6 median, and in RA was 5.2. And that points out another lesson, number 6, that the similarity of pain in OA and RA it was seen in many studies, but not explicitly articulated as a prominent finding, perhaps in deference to the conventional wisdom. Sometimes very hard to get your paper published if you criticize the conventional wisdom too much, as most of you know. This is a summary. It's a very busy slide, but you can look at basically, this is the first pain, rapid 3, or swollen joint count collected between 1979 and 1989. And this in green is the most recent. And what you can see is the most recent is not different and sometimes even worse for pain and rapid 3, but substantially different for the swollen joint count going from 12 to 1.4. But the median is similar to the first one, not the most recent one, except for the swollen joint count. Again, possibly providing face validity, but making an important point that I wish I could discuss at greater length today, but there isn't time, that the results of short and medium-term clinical trials in chronic diseases often are not translated into long-term outcomes. We know there are hundreds of studies in the literature which say that you can improve pain in OA, and they're all very good studies. Not all very good, but many are very good, but they don't seem to be translated into the long-term outcomes, at least for the most of the patients. It's also worth noting that even as before biologicals, OA scores from the first to the 6-month visit got a little worse for rapid 3, but RA scores improved substantially. And the same we could document at Rush in 2019, 12 years later. So it makes the point that rapid 3 improved in RA patients with treatment even prior to biological agents, while RA and OA patients showed little change in rapid 3 or the 0 to 10 pain score, as I showed in the earlier slide, which probably indicates some evidence, at least, of face validity of all these observations. It's also worth noting that the similarity of pain scores in OA and RA applies to many other rheumatic diseases. In fact, all diagnoses tested. It's a little lower in vasculitis and actually in metabolic bone disease, which usually doesn't present with pain, but nonetheless, the mean pain scores were about 4. And that hasn't changed over the years either. These are 3 studies published in 89, 2009, and now submitted for publication in 2025, showing the median pain scores, if anything, are in many diseases a little worse, possibly because of patient expectations, and the rapid 3 scores also are a little worse over the years compared to earlier diseases or earlier years. So the similarity of pain scores, and I would say in general, from the patient's perspective, whether they have OA, gout, rheumatoid arthritis, vasculitis, or spondyloarthropathy, they're very similar. Obviously, the pathophysiology and treatment are very different. We have to be aware of that, but we also have to be aware of the patient's feeling. Now, the discordance between symptoms and structural findings has been known for many years. This is a study done by Marion Hannon when she was a fellow with Dr. Felsen, published in 2000. I was sort of asked to comment on some of the observations they had made about education level, which was much poorer according to all three measures of osteoarthritis. They had radiographic pain or arthritis at any site. But the important observation was that only about half of the people who had significant radiographic knee OA had pain. This could only be established in a population-based study, which occurred in the 1970s when the United States was really a rich nation and had its priorities a little more appropriate than I think is the case today. It was also noted that only 15% of people in a population who had symptomatic knee pain had radiographic damage. So that is the 10th lesson, that much knee pain is not nociceptive based on structural damage, but may also be neuropathic based on nerve damage and or nociplastic based on pain sensitization. I wish I could talk to you more about that, but most of you know much more about that than I do, and this is a direction in which we're trying to do further research. Our most recent data on the subject have been conducted to extend the observation that pain and structure are not totally correlated. In Rush Clinic, this is Dr. Schmuckler, who's a young rheumatologist, researcher, Dr. Malfay and Dr. Block, who are very prominent editors of OA and C and well known to most of you, if not all of you. I'm very lucky to have these colleagues at Rush over the last 10 years. This is an analysis of 361 OA and 488 RA patients who filled out paper MDHAQs, showing that 40% met criteria for screening positive for anxiety, depression, or fibromyalgia of the OA patients, 36% of the RA patients. And I want to show you that anxiety, depression, and fibromyalgia, which were long recognized primarily in research studies as elevated in OA, RA, and many diagnoses, is easily screened for in routine care on validated indices on the MDHAQ, completed by most patients, I emphasize again, in 5 to 10 minutes. This is the first page, which I hope you may remember from a few minutes ago. This is the second page. We always limited the MDHAQ paper version to 2 pages, which includes a 60 symptom checklist, queries about morning stiffness, change in status, exercise, fatigue, recent medical history, demographic data, and a physician review to be signed, which we no longer use. I'll mention that this information actually saves time when you look at it. I only allocated, when I was seeing new patients, 30 minutes per new patient because I had a lot of information that helped me. And so in 2 hours, I could see 4 new patients, where many rheumatologists would only see 3 or 2 new patients. And there are lots of patients who never get to see a rheumatologist who should. So this was I viewed as a service to the community. Just to show you the actual indices, I can't show you how they were derived. Rapid 3 in the black is function, pain, and global 0 to 30. Fast 4, or for fibromyalgia assessment screening tool, has pain and fatigue. 6 of 10 on either of these gives you 1 point, and the RADI and symptom checklist, 16 of gives you a point. And if you have 3 or 4 points on these indices, it agrees 90% with the official fibromyalgia 2011 criteria developed by Dr. Wolf and his colleagues. Anxiety and depression are screened in the blue and green, one query in the HAQ format and one on the 60 symptom checklist. And these agree 80% with HADS, Hospital Anxiety and Depression Scale, and PHQ-9, the most widely used depression screen. And actually, they agree at the same level as the two reference questionnaires agree with each other. So it suggests that what we're collecting is moderately valid. It's interesting that when one looks at what's available on the MDHAQ, there's 7 constructs: physical function, pain, anxiety, depression, fatigue, sleep, and social participation. These are actually the constructs on the SF-36 and PROMIS 29, the two most prominently used generic questionnaire, this in the pre-2000 or 2005, and since then, at this time, widely used in many diseases. And only physical function and pain are available on the HAQ and WOMAC, which are still used in all clinical trials and most clinical care that uses questionnaires and don't include these important constructs, which turn out to be of great importance. Now, this column should actually be moved over here. I moved the MDHAQ to the left, but never got to this error. It's under PROMIS 29, but basically, none of the other questionnaires include joint count, symptom checklist, medical history, and indices for status and fibromyalgia. The lesson is that the psychometric approach, in the SF-36 and PROMIS 29, and the clinical approach, the MDHAQ, led to basically the same 7 constructs, which may be common to all chronic diseases, not found on the HAQ or WOMAC, but the MDHAQ also includes medical data concerning history, symptoms, and joints. This is a Venn diagram Dr. Schmuckler made just to show that anxiety, depression, and fibromyalgia, while they overlap, are not identical. Only about 20% in OA or in RA had all 3, and 19 to 27% had only fibromyalgia, and 10 to 20% had only anxiety or depression. It turns out that polyarthritis is important. This is an analysis that Dr. Schmuckler and Tengfei Li, who is our analyst, who's wonderful, formerly a student of George Luda at Chapel Hill, showing that polyarthritis, as Huskisson noted, is found in most patients. Only 16% of people with OA of the hip or knee had only one of those 4 joints involved, while 46% had all 4 joints. And these are the data from Australia. It's a little less, 32% in Rush Hospital, but again, only 17% had only one involved joint. And the median pain score goes from 5.8 to 7.5 in Australia, from 5 to 8 in Chicago, again, showing that the intensity of the pain reported by the patient may also reflect polyarthritis, in addition to necessarily the intrinsic severity of pain in a single joint. And this, in a sense, was noted by Huskisson in 1979. Furthermore, when we look at 1, 2, 3, or 4 involved joints, which I just showed you, these are the data from Liverpool and from Rush, that the median pain score goes up according to the number of involved joints, and also when there's a screening for anxiety, depression, or fibromyalgia, positive screens go from 5.8 to 7.5 in Australia, 6.5 to 8 in Chicago, compared to 5.3 to 6.5. So these patients, without, it isn't as though if you screen negative for anxiety, depression, or fibromyalgia, you don't have pain. You do, but it's less than if you screen positive. So that's lesson 15, that pain is raised by a positive screen for anxiety, depression, or fibromyalgia. This isn't only of academic interest. These are, I'm showing you now 10 years ago, ORSI clinical trials recommendations included a 0 to 10 pain VNS of 4 to 8.9 and a single target joint. Well, if you actually look, and I'm only going to show you the Australian data because we're running out of time, only 11% of patients with OA of the hip or knee had only one hip or knee and a pain score of 4 to 8.9. And actually, 20% of those, or 9% of all patients, had a negative screen for anxiety, depression, or fibromyalgia. So that ideal clinical trial candidates are not many or are a minority of all patients. Now, let me just point out some of the important limitations. I've already emphasized a few times that there may be better outcomes in other sites in the US and other countries, and anyone who does, please publish them or call them to my attention. It would be very important to learn. As I mentioned, the old literature contains lots of things that I'm afraid all of us may be ignorant about. There may be changes in implications and expectations of patients concerning self-report pain scores between 1979 and 2004, that most of the data, of course, are presented only in groups, as in most research studies, and possible important patterns in individual patients are not available, and that only patient self-report data have been presented. Possible differences according to medications, exercise, and other therapies are not included. Some of the future directions include formal comparisons of many different questionnaires on the same day in individual patients. I suspect we'll find what we found in these put together data, but it would be valuable to see just how much we can explain with these different questionnaires. We're trying to learn how to assess nosoplastic pain through self-report comparisons of the MDHAQ, Pain Detect, Central Sensitization Inventory with quantitative sensory testing. I don't think quantitative sensory testing, which has taught us so much, will ever become part of routine care unless someone can figure out how to get reimbursed a considerable amount, which doesn't seem likely in today's climate. But we can do a lot with self-report if we design the self-report optimally. We're trying to do some analyses of data from EPIC. We now have 30,000 iterations, but not all are available, coming in at 1,000 per week. And after the ACR meeting, this will be an important effort. And of course, I have continued efforts to introduce quantitative assessment, physical function, pain, patient global as vital signs for chronic diseases. My final two slides are some wisdom from earlier times, saying Fibonacci, who developed Fibonacci numbers, some of you may know about. If by chance I have omitted anything more or less proper or necessary, I beg forgiveness, since there is no one who is without fault or circumspect in all matters. And Plato, more than 2,500 years ago, pointed out that the greatest mistake in the treatment of diseases is that there are physicians for the body and physicians for the soul, although the two cannot be separated. Truer words were never said. Let me thank many people over the last 40 years who've helped with all this research, and I invite anybody who has comments, questions, or critiques. This is my email. I generally answer emails pretty promptly. I've had some very interesting and educational interactions with people over the years who have brought these things to my attention. So thanks for your attention, and I welcome any questions now and in the future by email.
Thank you, Dr. Pincus, for that wonderful presentation. There's so many great historical and clinical lessons in your talk. And we do have a few questions. I'm going to do things a little backwards today because I want to be sure we get to those questions, but I know some people may need to leave. So I'm going to just briefly mention next month's webinar on November 19th at 12 p.m. I'll put the link in the chat if you're interested in registering for that. And then I'll also be launching a poll here in a minute about today's presentation. So if you can answer those questions before you leave, I'd appreciate it. But I do want to open it up now. Dr. Pincus has generously agreed to stay on for a little while to answer any questions that you may have. So type your questions into the chat and I will read those aloud for discussion. And while we're waiting for those questions to come in, I just Dr. Pincus, again, thank you for that brilliant presentation. You shared 16 kind of messages, takeaway points that you wanted to share, and I would be curious to know kind of what the main what you want us to remember from today's presentation after hearing those 16.
Well, to summarize, the most important message is one, OA is as severe as RA. Two, most other rheumatic diseases are as severe as OA and RA. Three, we all need to read the literature more carefully. No more, that applies to me as much, if not more, than anyone else. And four, we should be collecting data in all routine care on pain as well as function and patient global, because these are really the vital signs in managing chronic disease. I point out function is predictive of mortality far beyond, it's the most significant predictor of mortality in rheumatoid arthritis, which Dr. Callahan and I observed in 1982, many years ago, but it's also true in congestive heart failure more than ejection fraction, in AIDS more than T4 T cell 8 cell ratios, in general in geriatric care. And it's really inappropriate for physicians to have a battery of laboratory tests and no information quantitatively about the patient's function that they can compare to from time to time. And ironically, there's probably more you can do about patients' function than a lot of lab tests. So there are lots of reasons to know that information. Thanks for the question.
And Dr. Pincus, I think you alluded to this a few times, but I want to ask, because you have the unique perspective of being a practicing clinician, you're still seeing patients, you are a teacher, and you're a researcher. Do you have a story or example from one or many of these roles that kind of explains how all of those roles inform each other and the work that you're doing today?
Oh, sure. Well, this could go on. Again, I want to make it clear that it not only does not take extra time, it saves time to have information available. I had a slide that I didn't have time to show of a patient back in 2003 who came in with classical rheumatoid arthritis, did very well for a year on low-dose prednisone and methotrexate, and then had a flare. And he said, "Doc, I'm just as bad as I used to be." And I showed him that he really wasn't. At the same time, I said, if you really want to get back to remission, maybe we should use one of these new things, which included at that time Humira. We had a lengthy discussion with him and his wife. This is 2003, so 22 years ago. We weren't as sure about the safety, and he decided to go on Humira, and 2 months later he was in remission. And I hear from him about every year he's still in remission, and he sends me a Christmas card. So there are lots of advantages to recognizing these issues with your patient.
Thank you. And so one last question for you. So we hear from clinicians that they don't have time to administer or even kind of process these PROs or other questionnaires that may be conducted prior to or during an appointment. So I'm curious what your thoughts are on the role of AI in kind of managing or providing summaries or flags to providers that are generated
Oh,
from these
that's a great
questionnaires.
question. I wish I had raised that, but you limited me to at the time. I'm a little worried about AI, not only in medicine, but in the world, as some people are. Let me point out that conversations in AI, which are being introduced, can save time, but they still don't provide quantitative scores. It's like saying a patient has a fever or a patient has diabetic ketoacidosis and managing it by the seat of one's pants rather than with numbers. It makes a world of difference to know that the temperature is 101 or 108, or the glucose is 300 or 1,000 in terms of what you're going to do for that patient. And I would contend that quantitative data has been essential to advances in medicine. AI is not going to capture quantitative data. There are also a lot of evidence that the patient alone writes more reproducible quantitative data than queries by an interviewer. I have seen interviewers who say, you don't have any pain, or seems like you have a lot of pain, and then they write the pain score as though that's objective. Having the patient with only a piece of paper and a screen is the best way to get the best data and to see if you're really making progress or you're just spinning your wheels, as we've shown with pain scores over these many years. It's also important to know that the short-term clinical trials don't necessarily translate to long-term data, because many doctors now say, well, they know the treatment works because it says so in the clinical trials. But we even showed that back in 1989, Dr. Felsen had a meta-analysis showing gold, penicillamine, and methotrexate had similar efficacy, which was true over 1 year. But we had an early database organized actually by Dr. Callahan in 15 private practices and showed that methotrexate was continued 60 months, where gold and penicillamine discontinued at 20 after by 20 was discontinued by 80%, whereas methotrexate only by 40% after 5 years. So we need to have quantitative data from the clinic to do our best for our patients. And I would again emphasize, it saves time once you learn how to use it. The first time you have to listen to the heart, it takes longer, but after a while you get good at it and you can do it efficiently. Anyone who wants any tips, I once had a program a few years ago supported by a pharmaceutical company. I went to doctors' offices to show them how to do this, and I'd be happy to do it if anybody's interested, because it's really a wonderful thing and it's helped me a lot. I don't see how you can see a patient without knowing their pain score and their physical function score. And believe me, I was once the director of the clinical immunology lab at Stanford University, so I know something about lab tests and their limitations as well. But thanks a lot for the
Well,
question.
thank you so much, Dr. Pincus, for sharing your expertise and for being an advocate for the patient's perspective. So we are very grateful for your time, and thank you so much to everyone who joined today, and we will conclude the presentation there. Have a great rest of your day.